I see a lot of people have come in, and it's 12:01 already. We can get started. So for another iteration of CPT Developer Chat, this is our final uh, chat this year. We've had a lot of good guests this year. We've talked about innovation and trends. We've talked about the healthcare ecosystem, AI and its impact. So a lot of good topics and a lot of good ground we covered this year. So, and I'm excited about this one as well. This is going to be more about updates and learning about from you as well. So, why don't we go over to the next slide, Dennis? So, before we get started, just wanted to make a note. Add your questions in Q&A anytime. Raise your hand and unmute yourself when called. This session will be recorded, like some of the other sessions that we've done, and will be made available on the AMA Intelligent platform. Please note, no definitive feature title is unless explicitly stated. With that, let's just get started. Dennis, you want to walk us through what's in store for us today?
Yeah, you bet. So we'll go through some regular program updates, some notes there, and then we'll hear from some of the dev licensees about what they're working on, kind of details about what they're experiencing, and then we'll have some additional community discussion. We have several topics to touch on. Really want to get your feedback and lean into a good discussion today. So if you have anything else you'd like to have us bring up, then certainly put it in the chat and we'll go from there. So first into the program updates, really just a high level of what the program looks like at this point. We have over 3,000 participants. That's fantastic, with over 420 licenses issued. That is continuing to grow strong, and we love to see all the different use cases coming in. We kind of loosely classify these use cases to get an idea of what people are working on, and claim management really stays the leader of the pack, followed by improving information. And so that is something that we see pretty frequently, where people are really trying to understand CPT, clinical information, and make a better either UI for people, for clinicians, or even back office people doing the claims work and whatnot. Really getting to the most effective information is a big one that we see. And then it's always fun to see the different analytics and other exploring use cases that pop up. We're really trying to pay attention to the whole landscape of different workflows out there. And as we think about future product development, we're trying to hit a moving target and think about what needs you all will have in the future. And so this input about what you're working on really does help. So thank you for that. Okay, so when we're talking about AMA resources, we usually kind of flash the list of things up here. Just a couple of notes that a couple of changes that have come on recently. One is that the AMA has released a report of CPT in value-based care. So that it's on the AMA website more broadly. We haven't added it into the resources area yet, but there's a link directly to it. And it goes deeper than other previous times that we've talked about value-based care a little bit, but this goes deeper into kind of where CPT supports VBC. And that is an area where we want to continue exploring and turn a kind of program view where what CPT is and how it's used in value-based care into kind of a data view. So how do we tactically make CPT usable in these different payment models? A quick note about PIN. It is closed for remodeling, is one way to say it. So they're pulling down the site to do some enhancements and whatnot. So if you've gone into there and participated in any discussions or matching, then just a quick note that is going to be shut down for a bit. I don't have a specific date when it's reopening, sometime in 2025. And then another quick one, we're working on rolling out our zip file API to the broader production licensee group. So you'll see more if you're a production CPT licensee. You'll see more on that coming soon. So with that, how about if we start with a couple of polls? Do you want to do poll number 1? Okay, so this just asking kind of what your affiliation with CPT licensing is, the CPT Dev program. Just trying to get a sense of who's in the audience today. Leave that for another few seconds here. Okay, so it looks like mostly split between in the dev program and dev license and not a CPT licensee or program participant at all. So good to know that. Thank you. And then how about poll number 2? So this really trying to understand like where you're at in terms of the innovation journey. You may be part of a company building something new. You may be just figuring something out. A lot of getting started, and then split between just here to listen and well underway. So yeah, just getting started, 60%. Right, early in the process. Okay. Thanks for that. Okay, so to get a better sense of what just getting started looks like, or being kind of early in the process, we'd like to do some dev licensee spotlights today. And we have a few different organizations who will just kind of talk about themselves and what they're working on. If you'd like, you can use these prompts as a guide too, to help give a kind of standardized view to the audience. You don't have to use these, but things like how did you get started? What problem are you solving? What challenges have you faced along the way? How are you using CPT, or how do you plan to? And then one thing that will lead into the discussion next is have you pivoted in your approach so far, and how did that go? So we'll get started. We have a few that volunteered ahead of time. Any from Covered Health, CD Resources, Tidemark, or Max? Any of you would like to go first?
I'm happy to start.
Great.
Can you all hear me okay?
Yep, sounds good.
Okay, awesome. Yeah, so in terms of how I get started, what problem I'm trying to solve, I came from a TPA, a third-party administrator, who was doing claims adjudication, and really focused on, tried to be as much focused on patient advocacy in that process. But as a TPA, you're also the insurer, so there's kind of a challenging balance there. I think the thing that struck me in my 4 years as a CTO there was that we were focused on all the things that we need to do for the employer. We obviously we also wanted to make sure we're serving the needs of the member and the patient. But at the end of the day, the employer is driving what value that needs to be delivered, since they're paying the bills. And so the problem I'm focused on is how do you go and serve and create an advocacy capability for people who are on individual health plans, because they're fairly underrepresented. Employers have the choice to go ahead and add advocacy or add other kinds of benefits to the health plans that they provide for their employees and their families, but on independent plans, there's really a lack of advocacy. And so the problem I'm trying to address is how to help consumers, or patients, depending on how you look at it, better understand healthcare around coverage, claims, and cost. So, and the reality is you can't enter that conversation without having CPT codes as the basis by which you help them understand, because that's the lingo that they hear from their provider when they're either doing a pre-authorization or they're looking at their EOB and trying to decide what it means and why it costs a certain amount. And almost no one in this industry is focused on going straight to the consumer because they don't tend to pay for anything. But AI has really opened up the ability to do this in a cost-effective way. And so I'm trying to solve for the problem of how do you help people who are on individual plans really understand their healthcare and know when they are being treated fairly and when they're not, both from a, like I said, from a coverage, cost, and claims perspective. So that's the problem. I kind of mentioned why I'm using CPT codes. That's really the lingo that gets communicated. In terms of challenges, I'd say, and this also addresses pivots. The reality when entering any consumer product world, and my background is I did 4 years in healthcare, but my background before that is consumer e-commerce and companies like eBay and Apple. The reality is you need to understand where to focus your attention, because as you all know, there are thousands of problems to solve in healthcare with data, and especially when it comes to helping patients and consumers understand their healthcare. And so my pivots are more around the discovery process. That's what I'm in right now. I'm doing some prototyping and validation of things. But at the end of the day, I need to focus on the right things, especially given that this is not the obvious path to revenue, which, in this world in general, you sell to payers, you sell to employers, and that's your obvious path to revenue. If you're focused on the consumer, a little harder to get there that way. And so that's a lot of what I'm working through right now as I begin to formulate and ideate on the right way to go to market.
Okay, that makes sense. When you're thinking about giving consumers more information and helping them get through that process, are you looking at it more of like a price transparency lens where you're helping them make decisions about where to go, or is it more of like, I know patient education is a big SDOH factor, where if they're more informed about their options and treatment plans and whatnot, that makes them more engaged in their care. Is there like a particular lane that you're trying to go down, or kind of all of the above?
Yeah, right now I haven't decided which the lane is. I have pulled in a lot of the price transparency, the MRFs, to begin to experiment. The reality is, and as many of you know who have played around with this data, and we used it at Collective Health as well, the reality is that the data is bad, right? Like, it's inconsistent. Even the provider information is fairly inconsistent, and so have to pick the battles in this case. So it might be related to that. I mean, certainly people want to understand. For anybody who's gone through it, it's almost impossible to figure out what something's going to cost before you do it. It's probably the only consumer massive expense that people don't have visibility before they get services, but only after, which shouldn't be the case, right? Like, that's just not acceptable. But that's probably not the first problem to solve. That will come later. The one foundational I will say, and this is something I think that's relevant for the AMA, is transparency is really important. And I don't mean just price transparency. I mean like understanding and transparency of what is happening, because if we're going to affect positive change in healthcare, we have to expose the data, and we have to do it in ways that people can digest, especially the lawmakers. And so if consumers are the basis by which that can happen, because I think there's an incentive for them to share more in order to get that transparency, then that's the way to affect change in a world where it is very, very controlled right now.
Mm-hmm. It does sound like there are a few different paths to improving how some of that information is being exposed. So like we spoke with an EMR that is building out better connections with payers, and so a lot of the rules around what's covered and what do things cost, so, all of that is getting pushed down, not nearly fast enough. And then the recent regulations on prior authorization are pushing payers to put their policies more prominently displayed, via API and online and things like that. And so hopefully more of those are accessible, and then that can help people make sense of them. I know some of the price transparency regulation dumped a ton of data out there, and that's been difficult to sift through. But it's at least a start. So maybe it's bit by bit. I think it is important for people to figure out how to take what is available and make it more consumable.
And that's the exact point, Dennis. I appreciate you saying that, because healthcare is complex, right? There's a lot going on behind the scenes, and the reality is, as much as some of the rules now making information more readily available is not it's not going to help if you don't know how to digest the data. So that's the challenge in this, and this is why I personally believe taking a consumer first perspective, like if you can help the average person understand what's going on, then you have the opportunity to understand where maybe more complexity exists than should. Provide more transparency in areas that are generating waste, to try and improve and help people understand how they're going to get effective care, right? Like that's at the bottom. At the end of the day, what matters is that the patient is getting the care that they should be getting and understands what the price of that care is going to be in a transparent way.
Right. Do we have any questions for Max or any other comments from the group? Okay, if anything pops up, just drop in the chat. Oh,
I just had one follow-up question, Max, and it's interesting you mentioned that AI is also having an impact in your space. Just curious to get your thoughts if you're implementing any specific use cases with AI at this point.
So the areas of implementation for me actually align with what I think a lot of the payers want as well, as how do you manage cost to serve from a member perspective. And I do believe one of the reasons that there's not effective advocacy programs for individual plans or just individuals as a whole is like it's too expensive, right? Like you can't hire a whole cost center full of people, or a call center full of people to answer phone calls for consumers who are probably not going to pay for that service. And so AI certainly on the conversational side, but even on the plan analysis side, right? The reality is when you as a plan member get information about your plan and what's covered and what the cost shares are and all that information comes across as a summary plan description or summary benefits covered document, which is it has some structure, but it's not super structured. It's semi-structured document. And so LLMs are great for pulling that data out in order to better understand and at least answer the question. Mostly, it's probably not going to be 100% accurate, but it's probably better than asking your neighbor what they think. And so, the question is the bar, and how do you manage expectations on accuracy? That is one of the benefits of going straight to the consumer, is you can manage that, whereas a plan can't do that, because if they give a wrong answer, they could be liable, right? And so I do think there's some opportunity to take advantage of AI in analyzing the plan. I've already done things to basically pull EOB data out into a structured JSON format to be able to, basically analyze CPT codes and pull the cost data from the cost sharing data. So that's pretty straightforward. But in the long run, really, Sandeep, what's necessary is to be able to do two things. Number one is um, get the EOP stuff in a structured way through through the EMR systems, and then also get patient records. Like if you want to do things like um, challenge denials for medical necessity and other things, you've got to be able to get into the doctor's notes. Otherwise, the doctor has to do it as well. And so, all the stuff that people are doing in pre-auth right now is great. And I've been talking to a lot of physicians about this, and they're like, the reality is you have these peer-to-peer conversations and they kind of go all over the place. And as much as you want to try and automate that, that one's going to be a lot more challenging.
Yeah, makes sense.
Yeah.
Thanks for sharing your perspective. That's great.
Absolutely, Cindy. Thanks for the question.
Yeah, thanks, Max. All right. Who's next? Brittany? I saw you come off mute, but can't hear you.
I actually have a quick follow-up question for Max, if that's okay.
Sure.
When you're pulling in that EOB data, are you also pulling in or will you be pulling in like denial of reason codes as well? Like for example, with the prior authorization?
That's the intention. I haven't done those use cases yet, Brittany. So I don't have that data yet. The part of this is I need to pull more example documents that people are getting, and the other piece is the other part of this equation is how do you get that data? Because one of the reasons I'm focusing on individual health plans as an example versus Medicare Advantage plans is the level of sophistication somebody has to upload a PDF. So this is why you have to connect to the EMRs, because then you can just pull the data directly, and all you need is consent from the user at that point. So there is a data acquisition challenge, and so the intent is to do that. I can't say that I've already done it, but the ability to pull this data out of those documents is actually quite powerful with some of the LLMs, especially with some additional training.
Yeah, when you get to that point, just let me know. I'll drop my contact details to you, and I can help you with that because we're a billing company, so we have a lot of that denial data as well from like payers, but it's all going to be in the mental health sector. But it should give you some pretty robust results.
That'd be awesome, Brittany. Thank you so much.
Great. Brittany, did you want to share about your company?
Sure. Okay. So I'm a mental health provider by trade. I'm an LPC. I also own a clinic, and then I've owned a group clinic since 2013, and then starting in about 2018, we basically started doing billing and credentialing services for other mental health practices nationwide. That afforded me to be able to niche specifically in Spravato and TMS services. And as you guys know or may not know, there is a new model of TMS that's getting approved by payers called SAINT. It's the SAINT protocol, but it affords like accelerated TMS. So what we've been specifically doing in our industry is working with the insurance payers directly to get the new accelerated TMS CPT codes loaded into their database. And of course they've had these codes for well over a year, but did they do anything with it with the insurance payers? No. So it's causing like denials with claims like across the board. So we've been working closely with the medical directors to, one, not only advocate that these codes be like loaded as soon as their policies start coming out, from the time that they write them, but then also working on streamlining those efforts. And one of the ways that we're streamlining those efforts is we're working specifically with key vendors in the AI space for clinical note taking so that those get dropped directly in, and with 4 different EHR vendors specifically, so that we can work on getting all of those codes straight from the clinical note down to the EMR streamlined. And our last and we've worked with that through their various API technologies or with their development teams directly. And so now what we're doing is we're now working with the insurance payers and working with various departments. There's about 4 different departments involved, including their development team, to be able to get those codes loaded into the database.
Okay, good
And
deal.
so, yeah, so I think
Okay.
one of the challenges that we've directly faced is all of the EHR vendors that we're working with, they've all like pulled in like different methods of like their coding development. And so that's really kind of slowed down some of the processes just in what they allow for their use cases, and then just in some of the rates that we can like push that data in specifically. It's really kind of like limited some of those transactions.
That was one of my questions is how has it been to work with the different EMRs? I know, some of them have some pretty sophisticated portals and APIs that you can connect with, but rules are all over the place. So any advice or lessons learned from working with these to, so like if Max is looking to integrate in the next year or something, any landmines to watch out for?
I can tell you that the easiest software vendor to actually have worked with from the EHR sector specifically is Advanced MD, because they do have a portal. They do have like a lot of documentation as far as like their API pools go, and it's relatively easy to integrate your API connection, get it tested out, and then get their software development team to approve that data. The other EHR vendors that I've worked with, one of them's well established. One of them's been around for about 4 years now. And the the third one that we've worked with, they all don't really, they have internal APIs, and that's really where we've hit some roadblocks, because they don't one of the EHR vendors specifically, they didn't even have a roadmap prior to me telling them they needed a roadmap. And so there's been hurdles like that, and teaching, just some of their own team, hey, this is how they didn't think about having a database architect on board or anything like that. So I think that
Mm,
some of having, unskilled labor on their teams has really kind of been some of the challenges that we've faced.
mm. I know some of the vendors that are like no code, integration vendors and things like that. Mixed
Mhm.
success there. Some are know what they're doing and some aren't as sophisticated. So
Mhm.
yeah, it does seem like a tough landscape to navigate.
Yeah, and I think too, if we had to do it over again, I would have considered, the clearinghouse vendors, as well, specifically,
Mm,
because what we were really working with, were a lot of vendors that had Change Healthcare, and so of course, with the outages there, and then some of those payment connections not coming back up until, just July of this year, really kind of like put a damper on a lot of our, workflow and projects and timelines for when we were supposed to get things done.
mm. And then have you run into, you mentioned something about updating codes and data.
Mhm.
Have you run into kind of uh, I guess, a mixed bag of like how often people update their information and what that's presented?
Yes. Yeah, 100%. So I can tell you, like, it mostly is where we've run into the biggest issues is with the Blue Cross plans, because all the Blue Cross plans have different technology that they're all utilizing. And especially if they get carved out to the TPAs, then they also have their own proprietary systems as well. And so we've run into the problems with that specifically because some of the insurance payers have been very good about updating their CPT codes in their database, and then other ones just really haven't been at all and didn't even like give it a thought. And it's been, we've
Mhm.
even had to get like the insurance commissioning team involved with a couple of the plans
Oh,
specifically.
wow.
And we've run into issues even so some of the insurance payers directly have been using like the 9-digit verify your address, like to verify like where providers are located, right, in their system. The 9-digit
Mhm.
zip code lookup, they're using that as a way to like maintain their database, even though they're not supposed to. And
Mhm.
so we've run into some issues with that because if you don't have like a DPV status of yes, which is, you can deliver mail to that address, and it's just an S that says, yeah, you can deliver it, but there's not an exact specific location for a suite number, it creates like a multitude of errors, and it creates like inappropriate denials or inappropriate rejections on those claims. And we're really kind of approaching this as more of this is a social, problem that we're facing, and we've got to do something about this to get it corrected and streamlined, because we've had a lot of clinics specifically wait like over 60 days to get their payments because, they've just had, what we're finding is, with the accelerated TMS model, specifically, there's mutually exclusive, like same day edits, not medically necessary. They're hitting up against all of those regardless of, modifiers that we're using, not using, and just allowing for like only 1 unit per day because that's what was, designed for TMS. And we're just running up against those issues specifically.
Okay. Any thoughts on, is it really like an upstream data quality issue? Is there room for technology to solve any of that? Like, I guess with a magic wand, what would you fix first?
So I think what I would fix first, like it is definitely an upstream technology issue, and it's really just about, a lot of these insurance payers specifically are having issues with their databases, and a lot of their databases are outdated, right? Some of
Mm,
them are like 10 or 15 years old. And so it's really kind of hard to get them to update anything because it's like a massive overhaul with like their entire
mhm.
system. And so if I had a magic wand, it would somehow be able to get somebody who had a little bit of lobbying power involved to say, hey, could we make these changes? Here's how we're going to do it. We're going to make consistency with all payers across the board, as far as just data integrity goes. But that's a whole problem for another day and probably a whole entire career path.
Is there
Mhm.
something that AMA does as follow-up for people who are licensees? I'm just curious because I think back to my collective health days as well, and I'm not sure what our process was for updating CPT codes, and I know they can change frequently, and that obviously impacts adjudication. So I'm just curious.
Um, we don't act as like the police or anything like that for updates, and uh, it's it's hard to give a specific instruction on things, because, like, for example, we have one annual update per year that is our big release, and then we have several smaller updates where it's a lot of things like PLA codes or vaccine codes and things like that. And so if a service or an organization doesn't use those codes, they don't necessarily need to update them. And so it starts to get a little bit odd for us to kind of dictate who updates when. But I will say that we are looking at how to make it easier for people to update content based on the files that they get from us. And so it's not a learning curve issue, because we've heard that too, where if somebody is responsible for loading updates and then they retire and there's nobody to come in and backfill them, and it's kind of a hard process to pick up, then maybe the updates aren't as efficient. And so we look at what are our files, how are they structured, and how does that support more efficient loading. And then we talk with a lot of the vendors, EMRs and payers and whatnot, about what their process is to update, and if they're having challenges, then if there's something that we can do to make that data more easily usable, then we explore that.
Sense. Thank you.
All right. Any other questions or comments for Brittany? Okay, thanks very much. Do we have anyone else who would like to share what they're working on? Oh, I think that might be good timing. Hey, Tal, we're going through some dev use cases. So if you'd like to share, this is a perfect time to jump in, but up to you.
Hey, I have no context. So, like, I have context on what this meeting is, but sorry for being late.
Sure, no worries. It's yeah, so just pretty much open forum on you know, kind of what people are working on. We have a few questions on the screen to use as a guide. You don't have to go by that, but really just curious to hear about what you're working on and
Yeah.
you know, what challenges you're facing.
Sure. So great to meet you all. We're Covered Health. We're developing a denial management solution for RCM. I'm sure you've heard of a few of those around. We've been around for about 1.5 years. The way we work is we collect a bunch of information from various sources and we connect to the providers. We sell to providers. We work with like betas and pilots with a few provider groups, mostly specialty. And the way we work is we try to recognize where they're having trouble and are the denials legitimate denials, like they should have been denied, or can we do something about them? And then we want to help them resolve those denials as efficiently as possible. So that's kind of what we're building. And we've been on the developer platform for, I don't know, a few months or so. We actually are working towards licensing it now. So if you guys are the people to talk to and give us an awesome startup discount, then please do.
Good to hear. Good to hear. Cool. What about any surprising things that you've run into so far? Like, are people, you know, do they think that most of their denials are not justified, but then you dig in and find that they are, or are there common themes that you run into?
I mean, this is a very long discussion that we can talk about, right? Denials is a denial specifically is like the last step, right? Last step of a payer conversation. They're like saying no. And then you have to, the ball is at your court and you can do something about it. Most of them are stupid and trivial and they require manual work or automatic work, but they're like easy to resolve or to write off. And as that case gets more and more complex, it requires higher level of expertise from the user that is working those denials. The person on usually an RCM person, coder, biller, sometimes also a provider, to have more and more information sources available to them, whether it's the AMA, various books, you know, coding guides, all those. Or other like payer policies, CMS policies, everything. And that's where we feel there's a gap at the moment. That's what we're building to solve for. Because the information is very segmented at the moment. We've heard someone say that for a medium to big payer, the payers don't know what's going on, right? For their own place, it's because it's such a big mess, right?
Yeah, that totally makes sense. Is that where you've seen technology help try to wrangle that, or is it more like process oriented where you just have to be the investigator that finds all those information sources?
So it's both. The way we're building our product is like a platform of different blocks. Some of them are more process oriented. Some of them are more, you know, AI driven and logic driven that you want to build to solve a problem. I'm sure, I don't know. Again, sorry for jumping late, so I have no idea what you guys talked about, but like staffing shortages in RCM are a big problem. Retention is a big problem. We're seeing it. We also kind of run RCM as a service in order to learn, have our own data, have our own users, right? And that way we know the actual challenges that people face when doing those things. Some are very dependent on the EHR that they're using, the PMS. You're not going to fix that, right? We're not going to fix that, by the way. Migrating like a provider group or a hospital is virtually impossible. So we try to blend in to their flow, whether through an integration or a point solution, to kind of improve their process.
I'm kind of curious if you've thought about like working with third-party billing companies to help improve those processes that you're currently like building out, because providers may think it's like, or in-house billers may think there's one way to solve something, but when you work with like third-party billers, they tend to have a more global view compared to just like individual clinics.
So yes, we have. This is I am, by the way, I lead kind of like the product and technology of the company. So and I brought on like joined because this is a developer chat. That is a very business oriented question. Selling to billing companies is very different than selling to the provider. The incentives are a bit different. The way they hire staff offshore is very different, right? So it's been more difficult, but if there is someone here that would like to make us awesome connections there, we're very open to it. And we do agree with you completely that we can do a one sell that can benefit a large number of organizations that way, right? Working with a billing.
So Tal, you mentioned that that data is so fragmented and all over, but you're looking to solve that problem. Do you think the data that you consume from AMA, or even for that matter, any other coding guidance that you consume, that if there was a magic wand, you would want it restructured or shaped a certain way? If you have given it any thoughts, let us know. Yeah.
So the short answer is yes. I would like it to be like I think there's work to be done there. I haven't since we're not licensed yet, then I haven't used the full capabilities that you guys offer. I think there's like when I talk about data, there's the AMA data, there's the CMS data are doing better than most others. And as you go more and more commercial, you go more and more, we don't care about you as a third party and we're going to do whatever we want. Same for providers. They don't make it easy for them. Right. And then some of them are very, very hard to get to. Like active work on you don't get to see anything that we have.
Yeah. That's hard. And I assume your product kind of then learns from various cases that it's seen over time and kind of keeps that data too, right?
Yeah, de-identified if we do it through different groups, and then for the same group, it's actually one of the highest values that we can bring is that two team members can work on the same case and they won't know it, right? The same problem twice, they won't know it. It's what Slack solves at the moment. We have an active Slack channel. I'm like, this has been asked before, right? Why are we doing it again? Those are the kind of things that we want to solve. And those things are actually the process things, because if a learning came in, unless someone manually inputted that learning somewhere, a manual edit would be the extreme case, but sometimes just like an SOP or a guidance, then it will repeat probably, right? Because it lives in someone's mind. And some of them use Post-it notes, but those are limited in real estate space on next to the screen with the person. Yeah.
Totally. Great. Thanks for sharing.
For sure. So can you did you guys give any intro on like can we work with you guys to what I asked on like licensing and all that, or
And Dennis, feel free to jump in as well. But CPT Dev Chats are like our community events to talk to our CPT Developer Program participants. We cover a bunch of various topics, but if you're ready to get licensed, you would notice there's a form link to which you can fill in as an interest form and get your process started if you know your use case. Or me, and you can reach out to me or Dennis offline and we can help you with the process. But yes, you're at the right place. We can help you with the process of getting licensed for the next steps.
All right, awesome. And by the way, I know there are like a bunch of people here that are listening, but we can see them. So feel free to reach out and ask. We're at coveredhealth.ai. Where like if you have ideas, want to collaborate, like we're an early stage startup, we're building and developing, so definitely open to any collaboration.
That's great. Thank you.
Yeah, thank you very much. All right, we'll get into a little bit additional discussion here. So the first topic, I think we covered a couple of these, but one of the things that we'll have in a future dev chat is a focus on just the process of innovation and where kind of best practices and the way that different product organizations think. And so one of the things that really jumps out here is like, how do you take the requirements from a potential client and incorporate it into what you're building? Is that something that you do actively, or do you try to like predict what your clients will want and build an MVP and then test it, or what does that look like for you? Any thoughts there?
For us, it was really like I kind of already had a pulse on like what our customer base really was looking for, because it was their same complaints that I'd heard for years. It was also the same complaints that I had in managing my own clinic, and the patients that we saw. So, but what we did prior to beginning to build this out is we took a massive survey, and I just posted it in all my online communities that we had of professional organizations, and asked people to complete the survey. And then we kind of ranked that in order for like what we were going to build out for them specifically and what it was that they were actually desiring, so that we could hit all the major data points first.
That makes sense.
So for
Any
us,
others? Okay.
just like the way we started is we started through a pilot giving a service to a specific specialty group. And as we grew, we realized that's great, and we learn a lot, and we get the data, we get some of the interaction with the people, but we kind of realized the best laboratory would be in-house, and that's why we kind of started that and started doing it ourselves. Because it is, now every feature that I have, I run it through a team of people, and they give me feedback immediately, and then I ship it to customers which use it. It's still very hard, and we use common product tools like Mixpanel and all of those to see what they actually use and all that. And eventually surveys, Zoom interviews, phone calls, Amazon gift cards, whatever gets them to talk to us. Yeah.
Yep, the incentive are sometimes the hardest part to get right. I get that feedback. Okay, good deal. Thanks. The next thing that I want to dive into a bit is some broader CPT data. So we've talked about how do you get customers to be using the right data? How do you index and classify data that you're getting? And so we're doing some product development on our end too. And so some of the things that I wanted to pulse check are first, if we're rolling out the hierarchy of CPT codes, so all the section headings and the code families and things like that. What does that look like for you? Is that something that you would use as like a grouping kind of feature, or I guess how would you use a hierarchy? And specifically, when we start talking about this data, we're also diving into a graph API, so you can kind of start with a pretty minimal bit of information and then get to a lot of CPT information based on that initial search. So any thoughts on how you'd use a hierarchy, for example?
How would a person, an RCM person, use that hierarchy? Like that's the first thing I would ask, right? If they use it and it's beneficial for them, then great. And we would use the same. The graph is more interesting, I think, for me, because that when you have to make decisions, it's usually between a few codes, and if they're not well connected or the links between them are not understood, you have to, like, that's a knowledge that exists somewhere, right? And
Yep. Yeah, that's a good call out. So I think that is where, yeah, we might see, if you are on a particular code, you could see kind of the family of codes. So that might help you understand the code relative to its immediate neighbors. And then using the hierarchy, you could jump up a level and say, well, what's the next immediate group of codes that are similar, but there's something different about them. So that kind of visualization is an interesting thing to dig into. Yep, thanks.
So I work at an EMR company, and it's fairly intuitive, meaning that we've built the product so it's based upon users' choices, documentation, and based on that, then we make a code suggestion for them. So regarding the hierarchy, of course, we would have a specific plan set up for whatever procedure that they may be doing. And when they choose that plan, based upon their choices within the plan of what they're doing, it would change the code based on probably the different descriptors that may be within the next code available in the hierarchy. So ultimately, that's where it would end up based upon their choices of additional things that may have been done to bump them to the next code and away from the parent code.
That makes sense. So using kind of code attributes to configure based on their preferences that they set up.
Right, because ultimately it's the code descriptions that are going to be slightly different when you move from one code to another code within that hierarchy. And it is the documentation that supports what they're billing. So that's why it's key that that's the only time it would move is when we confirm that the user has chosen something else to change that documentation.
Okay, good deal. I'll touch on a couple of other data points here in this same kind of conversation. So an index is another way to look at this, where it's a little bit more kind of concept based. I think not as rigorous as a hierarchy. But then another one that is on the opposite direction, more detailed, more granular, are different attribute tags. And so here we're putting things like a method that pertains to a particular CPT code, an anatomic site, an approach, and then these specific details that are associated. And so this we could see as helping to provide that separation between codes, but then also maybe another way to index and classify codes. So here I think the question is, would this extra level of detail be helpful, and like how would you use this different than the hierarchy maybe?
I think this extra level of detail would be helpful for us, and how we would be using it differently would be specifically like in our use cases, we do, and this would be assuming that, ketamine services get FDA approved and insurance companies start backing it. But for example, with the IV infusions, they do different methods for that. They do injections, they do saline boluses, they do injectables inside the saline solution. And so that would be helpful for us to know how to code it specifically, because it requires different modifiers. And so we would be using the attribute tags to specifically determine how the modifiers, which correct modifiers to place inside the software products that coincide with the CPT codes.
Okay, good deal. Let's see. And then with something like this, would it be more helpful to see what is like necessarily true in a code, or just like directionally right? And so, like an example there is for a code that is pertinent to a very specific part of the spine, would you want an attribute tag that says that, hey, this relates to the spine more generally, or just that very narrow part of the spine?
I would say that very narrow part of the spine.
Agreed.
Okay, great.
And we would
Okay,
probably
sounds
also
good.
like to use those attribute tags to know, can we use like different unit amounts or different CPT codes that could be utilized on the same day? We'd probably be using that as can this be used together? Is this true or is this false?
Okay, gotcha. Do you know, are those rules typically ones that come from the AMA guidance or from like payer guidance?
It actually comes from CMS specifically. And so we'd
Yep.
be using it in conjunction. It'd be your medically likely necessary edits, NCCI edits, those databases specifically.
Yep.
Which I don't know if you'd be able to actually have attribute tags based on CPT with that level of information, since you're really looking at all of the codes. We upload the NCCI file into our system. So after documentation's complete and the code suggestions are sitting there, we then bump it up against the NCCI file to confirm if the two codes can be built together or not.
Mhm. Okay, that's helpful. Like maybe that's something where we just need to have data that is compatible, with that. So there's no extra translation that you need to do from us to that. Okay, good deal. Let's run one more poll, and then we'll close it up here. So biggest challenge that your organization is facing. So we've got a lot of different things here on clinical workflow, streamlining, improving reimbursement, transition of value-based care, staffing shortage, interoperability. All right, looks like mostly improving reimbursement workflows, followed up by other. Okay, we'll take it. Well, thanks everybody. I think we're about out of time, so I'll wrap up by saying that we do want to make these dev chats really useful to you. So if there's something that you'd like to see differently, extra, should we have more speakers on a particular type of topic, or more frequent dev chats, less frequent dev chats, and even part of the program. Like one of the things that we're looking at is how to involve the program participants in more beta testing of features as it comes out. So if you have any thoughts about whether you'd like to do that, and kind of how much you'd like to do that, is that something that we should tap this group for an hour a month for, or would you rather have like a more intense, less frequent participation, something like that? All of that is great feedback for us. Reach out anytime with questions, comments, and can't wait to see you at the next one.
Yeah, thank you. We've really enjoyed these dev chats and interacting with you all. We always learn something new. I hope this is useful for you as well. And yeah, look forward to the next one. Happy holidays, everyone. Thank you. Bye.
Thank you.